Good afternoon, everyone. My name is Chad Worley, Lurie Childrens Physician Liaison for the City North and Northwest suburbs. I would like to thank you for joining us this afternoon as we introduce to you the Lurie Childrens team from the Division of Otolaryngology, Head and Neck Surgery. For this session, I am so pleased to be able to introduce to you Dr. Nancy Young, as she will be discussing what's new in the treatment of childhood hearing loss. During Dr. Young's presentation, we encourage you to engage in the questions room. In addition, you will see a handout available to download. This is a handout of our ENT team and where they have their clinics. But before we get to Dr. Young, I would like to talk to you about the Division of Otolaryngology. If I could just get to my slide. Sorry, folks. Our patient care helps save and transform children's lives. We provide medical and surgical treatment for children with disorders of ears, nose, and throat, as well as head and neck tumors. Our physicians treat more children for ENT conditions than any other hospital in Illinois. In fact, the ENT specialists perform approximately 40% of nearly 20,000 surgeries that take place here at Lurie Childrens each year. Our same-day ear to procedure program is available at both the main hospital and at Lurie Children's Outpatient Center in Westchester, and allows patients to be evaluated and have the procedures done all in one day. We are one of few pediatric hospitals in the U.S. that offer same-day appointments for minor surgical procedures. The team treats patients at the main hospital and 5 other locations across Chicago area, including Lincoln Park, Lake Forest, New Lenox, Northbrook, and Westchester. A multidisciplinary team of experienced healthcare providers will care for the child and help create a care plan. This team approach makes it easy for you to see every specialist the child needs under one roof, and often the same visit. I just want to let you all know that our new Skokie site is up and running, and we do have 20 specialties, including otolaryngology and audiology, which makes for great wraparound services that we have there for you. And as you all are well aware of now, kids are back in school, they're playing sports. This means more care will be needed for them. We are here to help you when your office is closed. With extended hours and walk-in services, our immediate care offers same-day medical services for the unexpected illnesses. We are located on the 8th floor of the Lincoln Park Outpatient Center and at our outpatient center in Northbrook. I would like to remind you all of the direct and dedicated physician-to-physician call line, Lurie MD. That's 1-855-LURIE-MD. Physicians can call to ask a Lurie Children's specialist for general recommendations about patient condition, to discuss any steps, or determine if a patient should now be admitted. Now for the good stuff, folks. I would like to introduce you to Dr. Nancy Young. She sees patients at our main hospital in Northbrook and in Westchester. Dr. Nancy Young founded the Lurie Children's Cochlear Implant program and is medical director of Audiology. She is fellowship trained in neurotology. Dr. Young edited the text, Pediatric Cochlear Implantation, Learning and the Brain, published in 2016. She was recently elected to the American Otological Society Council, the leadership body of the second oldest medical society in US. Now, here's Dr. Nancy Young to tell you about her practice here at Lurie Childrens and tell you what's new in the treatment of children and hearing loss. Remember, we encourage you to engage in questions in the questions room. Now, Dr. Young, I will give you I'll make you a presenter and give you the screen. Thank you so much.
Okay, well, Chad, thank you for that introduction to our division and for me as well. Can you see my screen, or do I need to click show my screen?
You need to click and show your screen, please.
And I will do it. Here we go. I'm showing my screen.
We are looking good. Thank you.
Great, thank you so much. So thank you everybody for being here today to listen. I want to touch base on a few highlights about childhood hearing loss. First, here is my disclosure slide. Today, I'm going to first touch upon congenital CMV in the context of it as a cause for sensorineural hearing loss, and what's new from a treatment standpoint and a diagnostic standpoint. Then I want to segue into why do we have two ears? There's something called a two-ear advantage, and the reason I want to talk about that is there is new indications for cochlear implantation to give kids the ability to hear from two ears who cannot at the present. And that is cochlear implant for what's called single-sided deafness, children with hearing in only a single ear who have sensorineural hearing loss of profound degree in the opposite ear, and children with asymmetric hearing loss, meaning one ear is treatable with a hearing aid and the other ear is has a profound loss and doesn't benefit from a hearing aid. And then finally, I'm excited to let you know about cortical auditory evoked potentials. There is a new test that our audiology department recommends in selected patients who are challenging to evaluate that really makes for more effective hearing evaluation, and we're one of the few centers in the country to offer this, so more to come. So first, congenital CMV. Most sensorineural hearing loss in children is of a genetic etiology, but of the non-genetic etiologies, congenital CMV is the most common. Most children with congenital CMV fall into the asymptomatic group. So they're not the kids that, based on their other symptoms, you would know that they have CMV. And in fact, in the literature, children with only hearing loss due to CMV are categorized as asymptomatic, which to me as an ear doctor doesn't completely make sense because they're symptomatic. They have hearing loss, right? But that's where they fit in the literature. So in the past, by the time we knew that a kid had sensorineural hearing loss, it was too late to get a definitive diagnosis of CMV in an asymptomatic child. So there's a new approach that's evolving. This is what's done at Lurie and what's done at Prentice and at a growing number of institutions. And that is to do the PCR testing for CMV the minute they refer or they don't pass the newborn hearing screening, be that one or both ears. So they're being diagnosed with congenital CMV before they get their diagnostic ABR. And that means that the diagnosis is being made during that sweet spot, those 3 weeks where we know the congenital CMV is truly congenital when the test is positive and doesn't reflect a postnatal diagnosis or postnatal, acquisition of the virus. And the Lurie ID clinic has a special clinic for these kids to be referred to that are asymptomatic but have hearing loss. They'll get them in a really timely manner. The evaluation for CMV will be done, and they'll have a wonderful discussion about the potential role for antiviral treatment to stabilize hearing and perhaps to prevent other neurocognitive issues. Now, CMV can cause bilateral or unilateral sensorineural hearing loss, and these kids are at risk for progression of hearing loss. So if they have normal hearing in one ear, the so-called normal ear is at risk with this history, and if they have aidable hearing, the ears are at risk to get worse. Effective treatment is just like for any other etiology or child, is dependent upon the degree of hearing loss. So we begin with the hearing aid, but if that does not give the child adequate access to sound, we will evaluate them as for an implant to see if they're a candidate. So moving on to why do we have two ears? Well, number one, better hearing and background noise, and that has to do with the brain. the brain is able to take input from 2 ears and use this bilateral input to screen out background noise, which is something that's important for all of us, but particularly for children, because we know that classrooms are noisy places, unfortunately. 2 ears are also critical for what's referred to as spatial hearing. That means knowing the location that sound is coming from. And once again, that's based on binaural input to the brain, figuring that out. Unilateral hearing loss, it's pretty much can't be done effectively. So now we'll move on to the topic of single-sided deafness. Someone with normal hearing in one ear and profound loss in the other ear. So this is a population in which traditional use of a hearing aid is not effective. It just doesn't give them information about spoken language because of the degree of loss. These children with unilateral hearing loss of any degree and type are known to be at risk for problems in school and are eligible typically for what's called a 504 plan. And because of this academic risk, our audiologists are going to recommend a hearing aid if a child has a mild or a moderate loss in one ear. But those kids with very significant loss don't benefit. And in the past, there was not anything we could do. So what happens to these kids with unremediated hearing in one ear? What unremediated hearing loss in one ear? So they're running on a single ear. What does that mean? Well, number one, there's increased effort in listening and therefore increased cognitive load. And this creates increased fatigue. And this extra effort and fatigue can impact attention and from there, behavior and social skills as well. And I think what's really fascinating about this is often unrecognized by the child and everyone else, because for most of these children, this situation has been true since birth or such early childhood that it's just their normal. And parents and educators either don't recognize there's an issue or attribute it to other factors like personality, attention problem, or just bad behavior. And in the past, children with hearing loss were simply given classroom accommodations, preferential seating. They might use something called an FM system. Sometimes we fit these kids with that can't benefit from a hearing aid with a routing device to send the sound to the good ear, but that doesn't give them true binaural hearing because we're not stimulating the deaf ear. So cochlear implantation was the first medical treatment that was effective to treat profound hearing loss. It involves stimulating the nerve of hearing inside the cochlea. So it's an ear surgery, not a brain surgery. And it doesn't function as an amplifier. A hearing aid is an amplifier. We're just turning up the volume. The cochlear implant actually makes the sounds that are part of speech clearer. So it gives people word recognition. And there's an internal implant with nothing sticking out, and then an externally worn component, and the system together is what helps the child hear. And this is computer programmed by a specially trained audiologist. And when implants were new, which was in the early 90s, they were only given to children who were profoundly deaf in both ears. And this child, Kevin, is an example of a child who was born deaf in both ears. He was implanted at 6 months of age, and here we see him at home at age 2 years. Oops, our video didn't play for some reason. Let's see if we can try it again. Here he is.
Yeah. Who did you play with today? Ben. Ben, and who else? Ruben. And Ruben. Was Mark there today? No. No, Mark wasn't there today. He's going home. He was going home? Yeah.
So we can see how effective a cochlear implant, especially when done at a young age, is to help a child who's completely deaf to learn to listen and acquire spoken language. But now we've moved into a new era as the technology has advanced and as research has advanced. And in 2019, the first cochlear implant system received FDA approval for use in single-sided deafness, as well as what we call asymmetric hearing loss. So in a situation where one ear is getting a lot of benefit from the hearing aid, but the other ear is not. So these are children, because they have useful hearing in one ear, they're learning to talk, but they don't have the two-ear advantage. And so now we can give that to them. And we find this is particularly compelling for parents of young children who know that the better ear or the normal ear is indeed at risk for hearing loss. So our kids with congenital CMV, our kids with bilateral cochlear malformations who we know are going to have progressive hearing loss, those parents are very, very interested. But indeed, you know, all children with sensory hearing loss are to an unknown degree at risk for progressive hearing loss. So I think this is an important treatment option. And this is something that the children are potentially a candidate for if the hearing loss was present from birth or of a delayed or sudden onset. And the shorter the period of auditory deprivation for the ear itself, the better. And insurance approval can be challenging because this is a newer indication, but we have been having quite good success in the last few years, I'm pleased to say. Now I'd like to segue a little bit and to talk to you about the Children's Audiology Department and their new test. Our audiology department is the largest in Illinois by quite a margin. We diagnose the most children with hearing loss, and we fit the most hearing aids in Illinois, and we're actually the largest cochlear implant program in the United States. Our audiologists have special expertise to test very young children and very difficult to evaluate children. That includes children with auditory neuropathy, which is an uncommon type of sensorineural hearing loss that's challenging to diagnose. And we're also expert at identifying children who might do better with a cochlear implant. As Chad was saying, we have many locations, including for our audiology department, you can see listed here, with Skokie being the newest location. Now we've just added within the last year the cortical auditory evoked potential evaluation, which is often referred to as HearLab. That's the commercial name of the test equipment. And you may be familiar with ABR, or auditory brainstem evoked response testing. So that test relies on the response of the brainstem to a sound. Well, this test evaluates responses of the brain's cortex in response to speech sounds. So much further down the line, okay? And this is a test where the child, it's not done with the child asleep. In fact, it's done with the child awake. And so this is a test we do not routinely do, but it's added to the test battery by the audiologist in specific circumstances. Typically when behavioral or behavioral plus ABR testing does not provide us with adequate information either about the child's threshold or about how they're doing with hearing aids. So it's really wonderful for infants and for children with delays or other diagnoses that make them very difficult to test through behavioral means. And it can be used to confirm degree of hearing loss. It can be used to fine-tune hearing aid fittings and to confirm implant candidacy in challenging cases. So that's the end of my highlights, and now I would welcome questions.
Well, thank you, Dr. Young. That was just an outstanding presentation. I gotta tell you, from your passion and dedication to the children it's remarkable. And you're helping so many kids like that boy Kevin out there. And You're just an inspiration to many of us. So thank you for changing the lives of so many people out there.
Well, thank you, Chad. I'm privileged to work at Lurie Childrens and to have the opportunities that I have to help kids.
Okay, so we have some questions out there. One is from Dr. James Olson, and he writes that he is seeing a newborn patient today who was born at Prentice, failed the hearing screen unilaterally, but was not CMV tested. How late is too late to test, and what is the best screen, saliva or urine?
Okay, so, well, thank you for this very useful feedback that I will give to Dr. Miffel, Lena Miffel, who you may know. She's everything I know about CMV, I've learned from Dr. Miffel. The more accurate test is indeed urine testing, but that is more challenging. So oftentimes when the kids are tested with saliva, ideally that the positive ones are reconfirmed with urine testing. Definitely, I mean, I think it's definitely worth doing within the first month of life. We've even had some kids where we've had the testing, where Dr. Miffel has kind of factored in a positive test even within the first 2 months. She'll do it in the context of the other evaluations she's done. So there may be some value there, but ideally the kids should be tested within the first 3 weeks. And then it's like crystal clear. Otherwise it becomes, you know, it makes the discussion with the family a little bit more, well, the odds are high that this is congenital CMV, but it sort of takes the 100% out of the discussion. It's a great question, and it gets into the art of medicine and the art of what Dr. Miffel does.
Okay, and then Dr. Young, you see patients downtown Westchester and Northbrook. Which days a week are you at Northbrook?
I'm at Northbrook 3 Monday mornings a month. The first, the second, and the fourth, typically.
Okay, great. Oh, another one just popped in. Why does a diagnosis of congenital versus acquired CMV make a difference?
Well, acquired CMV is not a cause of sensorineural hearing loss, other than in very super preemies, there can be an exception. But if children in the course of their life develop CMV, as we all do, that's not, that doesn't cause sensorineural hearing loss. But congenitally acquired sensorineural hearing loss does place them at risk. And in fact, the most common symptom that develops after congenital infection is hearing loss. I mean, many children, the majority, remain completely asymptomatic, at least as far as we can diagnose today. But the #1 symptom that will pop up is hearing loss, and it can be, in some cases, delayed. But the problem is all these kids that, you know, refer on newborn hearing screening, some of them do indeed have permanent sensorineural hearing loss at birth. And if we test them and we know they have congenital CMV at birth, and then when they get their ABR, the hearing loss is confirmed, odds are high that indeed the two are related, that hearing loss is due to congenital CMV. I hope that makes sense. But I'm not worried about acquired CMV in children as a cause of their hearing loss.
Sure. All right, well, I think that does it for the questions, Dr. Young. This is great. I just want to remind everybody, as I said, Dr. Young sees patients at the main hospital, Northbrook and Westchester. And to make an appointment to see Dr. Young, you can Rapid Connect or Epic Impact message. You can contact Dr. Young at nyoung@luriechildrens.org. And her office line is 312-227-6230. And if there's no other questions, I'd just like to thank you for joining us today. And Dr. Young, thank you. And if you have anything else you'd like to say before we hang up?
Yeah, I just want to say that my nurse, Candy Viverito, who's been at Lurie for many years, she's also someone you can reach out to if for some reason you don't want to or are having any difficulty reaching me. She's a wonderful resource as well. Thank you.
Okay. Well, with that said, thank you all for joining us. I hope to see you all at 3:30 this afternoon, where Dr. Ida will be talking about stridor management. And then at 5:30, Dr. Kathleen Billings will be talking about tongue-tied. And I'm still working on the enunciation of that one. So we'll just stick with tongue-tied, and she'll be talking about that today. So thank you all and have a great afternoon.
Thank you.